Manfred,
Hi, Katya.
can you hear me?
Yes, how are you?
Great. We are on air already, so I know that we have lots of doctors and nurses who are listening to us at the moment, and
Okay.
of people who are interested in what happened to COVID. We are basically like Netflix detective story about COVID. So tell us, if Israel started to do the second booster, which is the fourth dose, to whom and why did you take such a decision? Is COVID still perceived as a threat?
Okay, I'll say a few words. Thank you very much to you, Katya, and to everybody. I'll just say a few words again about COVID, which I'm sure you know almost as much as I do, maybe more. The virus is, as you know, a coronavirus, which is a problematic virus in that it mutates quite regularly. And so we have a regular change in the genetic makeup of the virus, and that's not unusual for the coronaviruses. The other problem is that we know that the response or the immune response to coronaviruses, even from the disease point of view, in other words, if somebody has had corona, it doesn't mean that they are immune from having another attack of corona. So basically, the idea of the vaccine is to boost your immune response and to try and maintain it at a level where at least if you do become infected, you have a milder disease and hopefully a very mild disease. So the question now of the next booster, I think I need to define when we talk about boosters, because I think the term is sometimes complicated. So I'll go back just quickly. The initial dose regimen for the standard, the Pfizer, Moderna vaccines, the mRNA vaccines, was a 2-dose regimen. And then there was a decision subsequently to add a third dose. So with 2 doses, one at 0 and one at something like, between 21 and 30 days, and some countries even gave it much later. But then there was a decision to add a third dose. So if we call that third dose not a booster, but a third dose, then boosters are really counted when we get to the fourth dose. So I think you're talking about that. So the fourth dose we have already given now to, we started off giving it basically to the older people over the age of 50 or so, 50 and 60, and people who are at high risk of severe disease. And those are generally people with chronic diseases, like chronic heart disease, cancer, diabetes, and so on. And subsequently, though, it was expanded, and virtually anyone can get now that fourth dose, which is, in a sense, the first booster, but some may call it the second booster. So I think, Katya, I'd have to ask you, are you talking about the fourth dose as the second booster, or it's just the fourth? Because it's confusing, right?
So then let's go once again, because different people are saying different things, and that's why let's clarify once again. Do I understand you correct that you consider the primary series of vaccination as 3 doses? First 2 doses and then the third one. Is that correct?
Exactly. Initially, the third dose was called a booster, but I think, certainly I believed, and I think many others, that it really was a vaccine that should be given in a 3-dose regimen. So it's a 3-dose regimen, and therefore, and the next dose after the third dose would be the booster, the first booster.
So then my question was about the booster, which is the 4th dose which people are receiving.
Right.
The
fourth dose now. Right.
You said that immunity is vanishing at some point. So at first I remember when people were receiving the 3rd dose, it was a question of half year waiting from the 2nd dose. Now I can see in the regimens of different countries and different recommendations that people are waiting for 3 months, and high-risk groups are waiting only for 1 month. How do you approach it? How do you see it? How long should be the period between the 3rd dose and the 4th dose? So basically between primary series and the booster?
I think we have to be practical, and I don't think that any of us really would want a vaccine which you have to receive every month or every 2 months and so on. So I think we really have to look at the data and say that basically people who have been vaccinated in the primary series, if we call the primary series 3 doses, and they have subsequently received the 4th dose, and in addition, they may well have been exposed to the virus, because we know that a very high percentage of the population, at least in the countries we're talking about, have been exposed to the virus. That means that there is a considerable amount of immunity. But again, we know that the virus is changing. So the immunity would be essentially to the vaccine you received and to the virus that you'd been exposed to. But there is cross immunity. In other words, you're protected even if you've been given the vaccine for an older strain. There is some protection against the newer strains, and that's the same would be for the disease. Similar in some ways to influenza. So I would say that we would be talking about the 4th dose. I certainly personally think that the 4th dose is only really warranted somewhere around 6 months after the primary series. And then subsequently, we would have to be careful about monitoring it. But I would guess, again, anything from 6 months to a year after the 4th dose, you might even then get a 5th dose or an annual dose. And that's something that's still being discussed.
Mm-hmm. And just to clarify, for the moment in Israel, all people are receiving it after 4 months, or there is certain difference and somebody is receiving it earlier than 4 months?
Right. I think it became a little bit more flexible, although the 4th dose should have been given 6 months after the 3rd dose. That was initially our policy. But then again, you know, there was demand for the dose and so on. So this was quite flexible. But I would say that if we wanted to talk about it in terms of policy, in other words, what would your policy be? To me, it would make more sense to say that we should wait 6 months after the 3rd dose to get the 4th, and then maybe again another 6 months between the 4th and any subsequent dose. And again, I mentioned maybe even longer.
Mm-hmm. Can you tell me whether Israel is still using only one vaccine as it used to be, Pfizer, or you are using anything else?
We used to only use Pfizer, but the Moderna vaccine is now available. AstraZeneca was also available here, but it wasn't used very widely, but it was available to those who wanted it. And those who had had some kind of reaction to the mRNA vaccine could choose to take the AstraZeneca vaccine if they wanted to. We do now have the Moderna vaccine also as an option.
So basically you are using mainly mRNA vaccines, correct?
Those are the most common, right? Almost all the vaccines are mRNA.
For the moment, the strategy for the target groups, target population for the vaccination, is it mainly basically, or was it initially based for booster with the people with some diseases or people of certain age, or healthcare workers as well were considered or are still considered a risk group, or not that much?
Certainly the targets initially were elderly people or older people, not necessarily elderly, but certainly over the age of 60, and sometimes we reduced it to over the age of 50. And we would be giving it to people who are at high risk of severe disease. Healthcare workers who are likely to be exposed to COVID were also included in the category that they would be given priority to the vaccine.
Mm-hmm. What about children? What is the current strategy with children? Because I remember you were one of the first countries who were giving it to children. So what was the coverage? How many doses children received? What's going on with children for the moment?
The vaccine has been approved for children in Israel. The same kind of emergency use approval that's been given in the US. The uptake has not been very wide. In other words, it's still at a low level of uptake. generally speaking, in the younger population, the compliance or the response to the vaccine, the taking up of the vaccine has been much lower than in the older population. So in the older population, it's been high, but in the younger population, it's been relatively low. And in children, it's still very low.
So for the moment, children of what age receive how many doses in Israel?
The children now, well, we've gone down. Basically, we've approved it for infants. It can be given as early as 6 months. And again, it's in the initial 2 months, 2-dose schedule. So at this stage, it's a 2-dose schedule vaccine.
And there is no 3rd dose or 4th dose for children, or there is?
Not yet, no.
Not yet. Okay. You started speaking about the compliance. How do people perceive for the moment this 4th dose? Is the consumption rate high? Is it still popular among the older people? So what is the coverage rate for the moment? How do people perceive it and whether they take it or not?
Overall in the population, as in so many places, there is this COVID fatigue. In other words, people are becoming maybe just a little bit tired of restrictions and vaccinations and so on. So that's affected the compliance. In the elderly or older people, the compliance is still high. So it's still, 80, 90%. But when you get to the younger people, it's much lower. And the 4th dose in the younger population the uptake has been much lower. I think for 2 reasons. One is that the disease, there's disease in the country, but it's still perceived now as a much milder disease, even though we are still having deaths and severe cases, but much less so than we did previously. Sometimes it's a perception problem because percentage-wise, we may be seeing less, but overall, in terms of severe cases, we're still seeing quite a lot of severe cases. But that's also because we're seeing a much higher incidence of disease. That's dropped, by the way, recently. The numbers have now dropped dramatically in the last couple of weeks. So we've dropped to a much lower level now.
Because of vaccination?
We think so, yeah. It's a combination, again, of exposure and vaccination. But the vaccination has been the prime reason, in my opinion, for the reduction. Certainly for the reduction in severe cases. Again, we still are not we don't have good evidence as to the extent to which it's preventing disease entirely, but it's certainly preventing severe disease. And as you know, there are very good estimates now that the vaccine has actually eliminated or averted millions of deaths worldwide. So it's very effective in actually reducing the death rate. In other words, very severe disease.
Speaking about quantity of cases, what is the testing strategy for the moment? Who is getting tested? How is it easy, not easy? Is it for everybody as it used to be, or you reduced the testing for COVID?
There's no real policy for testing. The testing now is pretty much if you feel that you have an illness. In other words, if you're symptomatic, that it's recommended that you test. And if you are in contact with people who have COVID, then you should, it's recommended you be tested. But for example, somebody who has been in contact with someone who has been diagnosed with COVID does not have to stay away from work. So there's no actual requirement that they be tested. It's just more a recommendation, but it's not something that's being enforced. There's no testing at the airport, although now they are reintroducing voluntary testing pretty much as you come into the airport. So it's still not going to be enforced compulsory, but you will have the possibility of being tested at the airport. That was not available. That was stopped for a while.
If somebody comes to the hospital with a high temperature, let's say, and some respiratory symptoms or severe respiratory insufficiency, this person will be tested for COVID?
Right. Sure, they will be routinely tested. And anyone who is hospitalized is routinely tested. So anyone who is going to be hospitalized is tested before being hospitalized.
Speaking about obligatory, for whom COVID vaccination is still obligatory in Israel?
You know, it was never obligatory for anyone because there's no compulsory immunization in Israel. We depend basically on the collaboration and cooperation of the public. But on the other hand, in many of the hospitals, for example, for healthcare workers, people who were not immunized could not work in certain parts of the hospital. So they were restricted in where they could work. So in that sense, it was a kind of a compulsory immunization, but it was not actually something that was enforced. There was a suggestion that this should be done for teachers and so on, but there was never really an introduction of a compulsory vaccination. However, just one other point, there were places that for a time, there were restaurants and so on, closed facilities, public facilities, where you either had to show evidence of being vaccinated or that you had a negative test. So that's not compulsory immunization, but it is something on the border of compulsory immunization.
And these restrictions, are they still in place? For example, going to the concert, if you are going not to the open concert, but to some big hall or to the theater, do you still have to show this certificate or not anymore?
No, not at all. That's not. You don't have to show the certificate. A lot of what is being done now is based on recommendations. For example, wearing a mask. So you'll see in many of the public places that it's recommended that you wear a mask, but it's not enforced. In other words, it's not compulsory, except for medical facilities. So if you go into a hospital or if you go into a clinic, then there is a requirement that you wear a mask. But again, you don't have to show that you've been tested.
Speaking about further, so to say, destiny of the COVID, do you think that the chance is very high that it will become, that it will seriously mutate and become very dangerous again, some new version of it? How likely is that?
Well, again, it's very dangerous to make predictions because somebody will come back to you and say, why did you say this? But let's just compare it, although it's not the same disease, but if we compare it with influenza, generally after pandemics of influenza, the virus has become endemic. In other words, it's still causing outbreaks and so on and epidemics, but it's usually causing what appears to be a milder disease. This may be due to two things. One, that the population is more immune, it's being exposed, and they're, again, vaccinated to a large extent. And also because it is possible that the virus does at some stage lose some of the virulence. This is, again, it's to some extent it's speculation. But even if you look at the pandemic of 1918, 1919, you remember as the years went by, that H1N1 influenza virus became less threatening. It didn't go away, it's still with us, but it became less of a dangerous virus. So if we are optimistic, we would say that the coronavirus now, because of the level of immunity in the population, this may in fact result in a situation where the virus then becomes less threatening. It's not in the interest of the virus to be too dangerous because basically, a virus survives well if it doesn't kill its host. It's not in its interest to kill the host. So we hope that that's actually what's going to happen.
Speaking
so I think
about,
it will become maybe a milder illness. Yeah.
Milder illness. Speaking about the target groups for vaccination, what about pregnant women? Do they receive, are they in strong recommendations to receive the fourth dose? And is the coverage good, and how this all works with pregnant women?
First of all, there is a strong recommendation to vaccinate pregnant women, and it's certainly pregnant women are at high risk of severe disease. And there's another benefit. There's now good evidence that the antibodies produced by the mother, the maternal antibody, do get passed on to the infant. So there is protection, presumably, of the infant in the first few months. So the vaccination of pregnant women is very important. And possibly it will be like pertussis, where they will recommend vaccinating women at every pregnancy, although that's not yet a policy. We still haven't said that, but it could be in the future. But it's a good vaccine for pregnant women.
And is it safe for pregnant women? What is now known more about the safety? Because a lot of pregnant women received this vaccine, a lot of babies were born. So how safe it is for the baby?
Right, the data, the safety data seems very good. There are no evidence of very real severe adverse effects of the vaccine in pregnant women or in their offspring. Previously we didn't have that much data, but now we've accumulated a lot of data. So I would say really that there is no good evidence that it's going to affect either the mother or the infant. In fact, I'm telling you things that you know, but the live vaccines can be problematic in pregnant women. But there's no evidence that the non-live vaccines, the kind of the killed vaccine or something like the mRNA vaccine, there's no evidence that it could do any damage to either the mother or to the pregnancy or to the infant. So I think that we can be fairly confident that it's a safe vaccine for pregnant women, and it's certainly effective in preventing severe disease.
If we speak about vaccine and what changes and some progress made with the vaccines, initially the big breakthrough was mRNA vaccine for COVID. Then there was very specific temperature regime for it. Then the temperature regime became milder and more simple. What are other changes in these COVID vaccines? What are the trends with COVID vaccines? And is there was a discussion that there will be one vaccine for influenza and COVID. Is this discussion still there, or technologically it's not possible and it will be two vaccines?
First of all, the mRNA vaccine has certainly been a breakthrough in vaccines. It's a new concept, and we don't have many new concepts in vaccines. So it's almost as, again, we could probably compare it with the conjugate vaccines that were developed for Haemophilus influenza, or the recombinant ones that for hepatitis B. So this is a new technology which has been very effective. I guess people are always a bit suspicious of new technologies, but this is really a very good technology. So I think that this is going to be a technology that's going to be developed further and further. The question of whether there'll be a vaccine that's going to cover multiple strains of the virus is still something that is a problem, as we know, for influenza virus. For years we've spoken about the possibility of a universal influenza vaccine, and there still does not exist. It still hasn't been developed. So I think this is still a challenge. I think this is going to take quite a while before we find a breakthrough. In other words, to find a vaccine that's going to produce antibodies that will target a common region of the viruses, which means that even if there's a change, the stable regions will be those that will be targeted. So that's still some way away. And as I say, in influenza, it's still not been successful.
If we speak about bigger picture and lessons learned for COVID for now, what are those for you? Because you are a university professor, you probably give all these lectures to students about the big picture, epidemiology, lessons learned, outbreak response. What are your, biggest lessons learned from the COVID pandemic?
There are probably many, but I think the first one would be the long period of time that it took us to react as I think we should have. And I think that's partly due to the fact that this is almost human nature. We don't like to believe that something bad is happening. So there is firstly what we, there's the whole concept says that there's a denial. And you can see it with everything else. And by the way, we'll talk next week about monkeypox as well. So when these new viruses emerge or new epidemics emerge, the first response seems to be that it's not true. It's not really going to be a big problem. So we don't have to worry about it. And I think that's a mistake. I think that we have to recognize that viruses and bacteria and all these agents are here to stay with us forever. They'll be here together with people wherever there'll be humans, there'll be viruses and there'll be bacteria. And they are going to be constantly in conflict with us. Sometimes we actually not in conflict and actually they're useful, but a lot of the time we're in conflict. So we have to be ready for that. So the early response should not be this denial. No, it's nothing. It's not going to be a problem. And that did happen in the beginning. And then there was this whole period of time, and I might even say it here, of blaming China and blaming this, and that's wasted time. It didn't really, China was to blame. It was a peculiar argument. I mean, it started in China, but the viruses, because some start in Africa, the so-called influenza of Spain started in the United States. So, and even I think the pandemic of 2009 of influenza started in California. So it can start anywhere. So to start blaming just wastes time and wastes energy. And I think we need to get very, very quickly, we need to get to the stage where we say we have a problem. We don't know how big this problem is going to be, but we need to cope with it. So we could well have put in restrictions early on and maybe limited the spread. I think that one good thing, though, was that the vaccine development was very rapid. And that, I think, was a very positive sign. Even though, again, people said it's a new vaccine and therefore we shouldn't use new vaccines. We need to recognize that in order to deal with these incidents, we have to work quickly. We don't have too much time to waste. So we can't spend too much time arguing about, the minor, shall we say, issues. That doesn't mean that the things like vaccine safety is not important. It's very important. But I think we have to recognize that it can be done in a way that is much quicker than we've done up to now. So I think that the vaccine development process is going to be much quicker now than it has been in the past. And I think that's something we've learned from this. But again, I hope that the final thing is, and we need many more people trained in public health. There was a huge problem of having highly trained people in the field, people who knew how to deal with the data, in other words, to analyze the data and to actually analyze what's happening and what could happen, and to actually introduce the preventive measures that we needed. So we need really now to spend a lot of money, a lot of capital on training new people in public health and in infectious disease, because there are very few that were being trained in infectious disease epidemiology.
Mm-hmm. Before we come to the next questions, I would like to read the questions which came from the audience. Lydia Lepeshkina is asking, which vaccine has to be as a third dose if the person received Coronavac as the first 2 doses? Can it be mRNA?
Basically, yeah, should I answer, right?
Sure.
Essentially, I think if you say the companies will always tell you to use their vaccine for all the doses, and I guess that's the kind of standard reply. From an immunological point of view, there's no real good reason to say that you cannot use a different type of vaccine for the second or third dose. And I don't think it was surprising that when they did give different types of vaccine for the different doses, because they combined AstraZeneca, which is and the mRNA vaccine, they gave pretty much good responses, good booster responses. Didn't really matter which way. Although the mRNA vaccines tend to be more immunogenic, so they produced a higher response. But there's no safety problem giving different vaccines. In other words, you don't have to be concerned that it will cause damage. But you may get slightly different responses. If in fact, for example, if mRNA is giving the best response, and you've had 2 mRNA, and you have AstraZeneca, for example, you may get maybe a slightly lower response. That's not because you're combining vaccines, just the way in which these vaccines operate.
The next question is, the next comment is the following. Oksana Krasiuk is writing, we are now in Poland. Masks are in the hospitals, polyclinics, obligatory. In the transport only if you want to, and sometimes I see people in the shops. So the question is, for whom the masks are good, for whom they make sense now, you think? For whom you would recommend in this season to wear a mask?
Right. The restrictions that were introduced, for example, and the main restrictions were masks, were what we would call social distancing, and the shall we say, personal hygiene, hand washing, and all the rest. Masks are not 100% effective, but there is now good evidence that they do reduce the spread. And in fact, the best evidence is, well, it's not just masks, but the best evidence that these so-called interventions that are not vaccines, just the other interventions, masks and social distancing and so on, in other words, is that influenza practically disappeared. So that was not because the influenza vaccine was being used. In other words, this was actually impacting on influenza. And by the way, on other viruses like RSV, many of these viruses just became very rare during the time that these restrictions were put in place. Also, travel restrictions affected it. So, and I think that from other data, masks have a positive effect. In other words, they are useful in preventing spread of the disease. The question now is, how inconvenient are they? What is it a problem to use them? So I would say that we would find a middle road and say, okay, it makes sense to use them in medical institutions, and whether it's hospitals or clinics. Everyone should wear a mask. I think we're protecting the others and we're protecting ourselves, and certainly we don't want to infect people who already have some kind of problem, and that means that their problem would be even worse. So this would be protecting ourselves and also others. I think that in areas where you feel that there are people who are at high risk of severe disease, it makes sense. I would certainly suggest that elderly people who go to the shopping centers and so on, I think it would be good for them to wear masks, because I think they should protect themselves. And I think it's useful. And I don't think it's too uncomfortable. So public transport, I think, would be a good place where we should consider having masks as being part of the regular behavior. The question always will be, should this be enforced by law, or should this just be a request to the public? At the moment in Israel, as I said, it's a request. I don't see that it's being done very widely. In other words, if you just ask people to do it without enforcing it, it doesn't seem to have a huge effect. But I do see quite a lot of the older people wearing masks in public places. So certainly those who are at high risk, I believe, should continue to wear masks when they're exposed in public places.
Another question is from Alona Pogrebnaya with regard to the teachers and those who work in kindergartens. Is it obligatory for them to get vaccinated in Israel? You said that, I think not, if I remember correctly. And do they have to wear masks? What are these regulations now for schools and kindergartens?
Right. This was a controversy in Israel, and certainly there were efforts to try and enforce, or at least make sure that the teachers were vaccinated. I think that, again, it has to be part of a persuasion. I think that someone who is not vaccinated, at least as long as there's a fair amount of disease around, I would suggest that they wear masks. I can understand, though, the problem of wearing masks in kindergarten. Let the To make the children, those very small children, wear masks, I don't think it makes sense. I don't think it's fair, although I've seen it done, but I really think that's not easy for little kids to wear masks. It's not good for interaction between people. The question here is if the teacher is wearing a mask, that's not going to interfere with the relationship between the teacher and the kids, because they don't see each other's faces. Again, I don't know where you are, maybe it's a little bit more difficult, but as much as possible to teach the kids outside, have lots of outdoor activities, and limit the amount of time that they're actually spending indoors. I think that would be a good way of reducing it, as long as there's quite a lot of disease around. Where it's convenient, wear masks, where you think that kids are, certainly where the teacher's going to be in a closed space for a long time, it might sometimes mean that they should wear a mask. But I don't think at this stage we could really enforce something like that. But I think that they should be vaccinated. Mm-hmm. I would think there should be strong campaigns to encourage people who are in public places or teaching or exposed to public or exposed to children, that they should be vaccinated.
There are two more concepts which I would like to discuss. One is the safety profile of vaccines and what we know about it now for COVID. And another is how you can be sure that your patient or you yourself is protected. Let's start with the protection. Do I understand correct that if the person has some comorbidities, or the person is of certain age, or the person is pregnant, do I understand correct that we can feel calm, so to say, only if this person received 3 primary doses and the 4th dose of booster, and then we are calm that the person is protected from severe disease, correct or not?
Certainly the first 3 doses are, in my opinion, essential, right, for protection. And again, we have to remember this, we're not talking about 100% protection, as for many other vaccines, but certainly a very high protection against severe disease and generally high protection. The 4th dose has been shown to give additional protection, but not the same amount as the 3rd dose. In other words, there's a decline in the amount of additional protection given. But it seems to me to be advisable. Again, we're talking about a vaccine. In any event, the vaccines will not be 100% protected. So there will be breakthrough infections and sometimes even severe infections. And that's true, I guess. But it's still better. It's not better than the influenza vaccine, by the way. The results have been much better than the influenza vaccine. So it's in that sense, it's a good vaccine. And I think that we should, in fact, try and get to 4 doses for people who are at high risk. I think that's pretty much the minimum that I would believe is necessary. And then later on, because of the change in the virus, this again would have to be updated probably at a later stage.
If we speak about children, let's say parents are worried for their children who will spend time in Ukraine a lot in the shelters because of the war. So there will be times of the air strikes and people would spend for a couple of hours in the shelter. So if the child received 2 doses of vaccine, is it enough, or still it's a question of the regime same for the adults when it's better will be 3 or 4 doses of vaccine?
Yeah, at the moment, I think on the basis of the data that's available, the 2 doses in children would be sufficient at this stage. Children generally respond much better to vaccines. They get a better immune response. So I would say that from what I've seen, that the 2 doses, and I wouldn't impose too much on the children having more doses. But you're right, there are these special situations, as you say, where kids are kept in shelters for long periods of time. So I would certainly monitor the disease there. And if you see that, in fact, there's an increase in breakthrough infections, in other words, kids who have been vaccinated are getting sick, you would certainly consider giving another dose. In the shelters, You may be able to tell me, because I mean, we have that in Israel to a much less extent now, but we also have kids in shelters sometimes. You would ask also whether they should be wearing masks. And again, we don't want to impose too much on the children, but if it can be done in a way where it's not too oppressive, then again, wearing masks would certainly be advisable in those closed spaces.
When you say that children respond better to the vaccines, do we mean children under 16, 12, under 18? So if we take a child, for example, of 16, are we still talking about the 2 doses, which is enough, or more doses are needed? Or it's still a child and
Right.
Anybody under 20 is responding pretty well and we shouldn't be so worried?
Right. Younger people generally, I mean, as you go up the age, it gets a little bit less, but certainly under the age of 20 or so, these are people who generally respond very well to vaccines. We've seen this with virtually all the vaccines, and there's no reason to suspect it won't be the same for COVID. So I think there's a good response to the vaccine. But again, we have to keep monitoring this, because again, this is another vaccine and another virus. So it may not behave exactly the same as others. But I would say that at this stage, if you ask me whether to add a 3rd dose, as I said before, it seems to me that the vaccine is much better, or it makes more sense as a 3-dose schedule. In other words, it should be always given it. So, if you can give them a 3rd booster dose, that certainly would be very helpful. I'm not saying that 2 doses is not helpful, but I think the 3rd dose would certainly be an additional booster, and it might well be useful. This is something, though, that we need to follow carefully and get more data, because I don't think we have enough data on that.
Mm-hmm. With regard to safety, people who received the doses of corona vaccine basically experienced some unpleasant issues, like, for example, high temperature or general feeling of weakness, and it's not a very pleasant vaccine, I would say. What do you see after the 4th dose? Is it worse than we had during the 1st, 2nd, and 3rd? Is it the same? What do we know about the safety profile of this 4th dose and about the feelings of people?
Well, there seems to be less at the 4th dose. So, in other words, it doesn't increase and probably decreases. So there's less of a severe response there. Just an interesting thing, work that we've done here and published, is that the side effects of the vaccine are twice as common, or more than twice as more common in women than in men. So women, and this is true in children as well, by the way, girls get more high. This is, again, probably due to the fact that they usually have a stronger immune response generally, both to vaccines and to infectious diseases. And we know that for autoimmune diseases, they are much more common in women. So it's not unexpected that if you look at the reported side effects, a lot more are in women than in men, and that's pretty much for all the vaccines. Mm-hmm. So it's a vaccine. The mRNA vaccine does have, it's quite what we would call reactogenic. It does have quite a lot of side effects. They are transient. In other words, they don't stay with you. They're with you for a couple of days. But it's true that you can have fairly severe in the sense that you feel very bad for a day or two after you get the vaccine. That's true. It's a vaccine that's stimulating a very strong immune response.
Speaking about giving vaccines at the same time, do I understand right that people who are coming to get their COVID vaccine can in Israel receive their diphtheria, tetanus, or influenza, or pneumococcal, or any other vaccine, and the same with children, correct?
That's true. Here I would be just a little cautious. We know that when you give vaccines together, there may be an effect of one on the other. So the response to one of them or more may be less. And we know that pretty much for all the vaccine. For the COVID and the influenza vaccine, for example, the response, the immune response to the two has been a bit lower if you give them together, but not very much lower. In other words, it does, according to at least the conclusions of the people who've done the studies, it doesn't seem to affect the protection, the level of protection. It just means your antibodies are a bit lower, but the level of protection is pretty much maintained. What is problematic sometimes are the side effects, because you can get, if you get a vaccine, COVID vaccine together with an influenza vaccine, and then you have side effects, you don't know where the side effects have come from. So this may actually make people nervous. In other words, they may think either that it's because you received two together or blaming one or the other. But it may be the same. So in other words, if you're going to have a fever after the COVID vaccine for 2 days, let's say, and which is quite unusual, but it happens. And then you have it with the flu vaccine, you won't know whether that fever was from the flu vaccine or from the COVID vaccine or both together. There's nothing dangerous there, but it may make people perceive the vaccine as being problematic. So you may find the public, when they get them together, telling you that they actually was having a lot more side effects. They may have a bit more side effects because they may sometimes get it from the one and sometimes from the other. But it's not actually because they're interacting with each other. It's not as if they're actually affecting each other.
And the last but not the least is the question, when the person had COVID, can you say that it's equal to vaccination? Because this is the general immunity. And I will widen this question, which came from Zinovia to Facebook. What is the strategy with those who had COVID? How do you vaccinate them? How many months you wait? Is it the same as with everybody else? Because if you remember in the beginning, there was huge debate on that, and then it kind of changed. So what is the trend now?
Well, I'll start off by saying that we have had to change some of our concepts in immunity and in vaccinology. Again, you'll remember well, or you know well that, for example, for measles, we often said that people who had measles did not need to receive a vaccination against measles. And that's how we often define groups. Anyone who was born before the vaccinations were in place and that probably had measles didn't need to be vaccinated. Now it does seem, though, that that's not a consistent finding with all infectious diseases, and that in fact it does seem, first of all, we know that people who have had COVID can get reinfected, and we've even had now reports of people who've had 3 incidents or some of 3, shall we say, diseases from COVID. They've been sick 3 times. So you can get sick again. It does seem from the data as well that the vaccine gives you better immunity than the actual disease. Now we're talking about fairly new vaccines, so this also may be because of the technology. I really only know of data coming more from the mRNA vaccines, but it may be true of the others as well. So here you have a situation where we're saying the vaccine is better than actually getting the disease in terms of producing immunity. You would be more immune from the vaccine than from the disease. So that's one of the concepts that's around now. As a result, and partly it is recommended that people who have had COVID should still get vaccinated. So in other words, if you've had the disease, it's recommended that you have at least 1 dose of vaccine as well. They may modify that later, but it is an additional basically boosting of the immunity. So this is a little different from what we did in the past. I think you'd agree that if someone had hepatitis B, you wouldn't recommend that they have the vaccine because they'd be this good solid immunity or hepatitis. But for the COVID one, and this may well be true for many of the respiratory viruses, many of which we don't have vaccines, like RSV and so on. It's just that we don't get enough solid immunity from the disease. or influenza. We may possibly again. It's possible, I guess, that people could get repeated infections. So again, with COVID, I think the general recommendation is, even if you've had the disease, get a vaccination, an additional dose.
I'm checking whether we still have questions. We don't have questions for the moment. So for everybody who was in this webinar with us, we thank everybody who was in this webinar with us. And the next week, we will be coming with the monkeypox, which is very popular topic now. So prepare your questions and send us your questions. Всім, хто нас дивився, дуже дякую. І ми чекаємо на ваші питання стосовно обіз'янної віспи. Ми будемо з Манфредом на наступному тижні про це розмовляти також у такому вебінарі. Тобто чекаємо на ваші запитання. Manfred, thank you so much. I hope that the victory will be soon and you will come to Kiev soon.
Katya, I first of all want to thank you very much. And I want to say to everybody that we are very, very worried about you. We are very much supporting you. We are absolutely disgusted by this invasion of your country. And I think that we are very hopeful that this will be, you will be victorious. I see the way that you are coping. We are absolutely, we admire you. We admire you tremendously. And if we can help more, we'll help more. My wife, as Katya knows, my wife has just come back from spending a few months in Ukraine as part of the World Health Organization. She was leading the World Health Organization delegation or mission in Ukraine. So I know a lot about it, and I really very much, I'm with you. We all are. We're all with you, and we really hope it will be over soon.
Thank you so much, Manfred. See you next week with the monkeypox topic.
All the best.
Всім дякую, всім мирного дня.